Good afternoon, everyone. It's a lovely Saturday afternoon here in Singapore, and I hope that you are enjoying your day and the ASPA conference wherever you are in the world. Thank you for joining us in the Neuro Anesthesia track, where we have endeavored to gain nuggets of wisdom from pediatric neuroanesthetists at various stages of seniority in practice from all around the world in a panel discussion. My name is Karis, and I am a consultant in pediatric anesthesia at KK Women's and Children's Hospital, Singapore. Please allow me to introduce the panel that we have today. Firstly, we have Dr. Manikandan Sethuraman from India. He is the Associate Dean, Professor, and in charge for the Division of Neuroanesthesia, Neurocritical Care, and Department of Anesthesiology at the Sri Chitra Tirunal Institute for Medical Sciences. He has multiple research interests, some of which include neuromonitoring and neurocritical care. To date, he has published 72 articles and 5 book chapters, and is no stranger to speaking at national and international conferences. Our second panelist is Dr. Geraldine Jose from the Philippines. She is an associate professor and consultant in neuroanesthesia, cardiac anesthesia, and intensive care at the University of the Philippines, Philippine General Hospital, for which she is the neuroanesthesia clinical lead. The hospital runs a busy neurosurgery service of 1,000 plus patients a year. She has previously completed research and clinical fellowships in neuro and cardiac anesthesia at the University of Toronto, Canada, and is heavily involved as an examiner and accreditor for the Philippine Board of Anesthesiology. She currently serves as a member on the Executive Committee of the Asian Society of Neuroanesthesia and Intensive Care. The third panelist, Dr. Nicholas Lanyon, is a consultant in pediatric anesthesia at the Royal Hospital for Children, Glasgow. Having completed his FENSCA in 2018 and a provisional fellowship at the Royal Children's Hospital, Melbourne, he has undertaken further fellowships at Great Ormond Street Hospital, London, and the Royal Hospital for Children, Glasgow. He has an ongoing interest in the care of the complex child, critical communication, and complex airway management. Our final panelist is Dr. Pang Ye-Yun, who is a consultant in anesthesiology and critical care at the Hospital Tunku Aziza, Women's and Children's Hospital, Kuala Lumpur, Malaysia. She underwent a subspecialty fellowship in pediatric anesthesia with the Malaysian Ministry of Health and completed an international training program in pediatric anesthesia at Sheffield Children's Hospital, UK. Her interests include pediatric sedation, pre-medication, pain management, and pediatric regional blocks. With this good spread of worldwide experiences, today we will look at discussing 2 case studies. Firstly, we will start with a posterior fossa tumor case discussion, and then in the second case study, we will follow the journey of a child with traumatic brain injury starting from the ED. We hope that we will be able to offer practical tips and solutions and provide answers the common dilemmas or questions that arise in these type of scenarios. At the end of the case discussion, there will be 10 minutes for Q&A, so do please post your question on the chat. Now, if you have a question for a certain speaker, please do indicate the speaker that you wish to direct the question to. So, without further ado, let's launch into the first case discussion. I would like to invite Dr. Geraldine Jose to be a co-moderator for this case, and also invite Dr. Pang Ye-Yun to share the case that we are about to discuss. Over to you, Dr. Pang.
Thank you so much, Dr. Koo, for your introduction. I would like to share my screen now. Good afternoon, everyone. I'd like to present a case of posterior fossa tumor with obstructive hydrocephalus, which happened in my hospital. This is a case of a boy, 1 year old, 8 months. He's born term at 39 weeks, current weight of 11.2 kilo. He has underlying laryngomalacia under ENT follow-up, but has been discharged ENT. He presented with vomiting for 18 days, 2 episodes per day, and usually post-feeding. Is moderate in amount and non-projectile. He also have abdominal distension for 17 days, and he refused to walk for 4 days. Premorbidly, he was able to walk unsupportedly. There's no fever, there's no upper respiratory tract infection, no recent fall or trauma, no history of seizure. There's no changes of behavior and still able to tolerate orally. However, there is abnormal CNS examination on arrival to hospital. The tone was normal bilaterally. However, the power showed 4/5 upper limb and lower limb bilaterally, with brief reflexes bilateral upper limb with 2+ and bilateral lower limbs 3+ of reflexes. The Babinski was upgoing bilaterally. The GCS was full with pupil reactive bilaterally. So they proceeded with CT scan in Purple Hospital and showed posterior fossa tumor with hydrocephalus. As you can see, the ventricle was big and the brain tissue was compressed against the skull. Antibiotics was started to cover for meningitis. No lumbar puncture was done, and subsequently the child was referred to neurosurgical team in Women and Children Hospital, Kuala Lumpur. And then right frontal ventricular peritoneal shunt subsequently was done, and MRI proceeded 4 days after the VP shunt insertion. MRI showed heterogeneous intraventricular lesions seen within and distant the fourth ventricle. He demonstrated heterogeneous T1 WI iso to hypointense signals and T2 WI iso to hyperintense signals. There's more enhancement on post-contrast study, and this is a posterior fossa tumor, and child underwent posterior fossa craniotomy and excision of tumor in prone position. As you can see, this child is lying prone on horseshoes, and I will pass over this case to Dr. Geraldine to host the panel discussion. Dr. Geraldine.
Dr. Fang, this seemed to be a very challenging and complex surgery for a pediatric patient. How do you go about counseling for major neurosurgical procedures for this type of patients?
For major surgery, we will usually ask the primary team to send the patient with parents to our anesthetic clinic, and where in which we can do a proper pre-operative assessment, and we convey the issues in pre-operatively, intraoperatively, and post-operatively. So for pre-operatively, mainly we will discuss whether patient need to be optimized or resuscitated if patient it's under volume or dehydrated due to prolonged vomiting. Intraoperatively, probably I will convey the issues of pertaining to posterior fossa tumor surgery, because it's close to the brain stem, close to the baroreceptor. Probably there's the changes of blood pressure, or there's and because it's close to the brainstem, and it causes the respiratory center, affect respiratory center, and patient may unable to breathe post-operative and need to be ventilated in PICU. This probably I will tell the possibility of tracheostomy because of unable to breathe and the respiratory center is affected. How about Dr. Manikanda? How do you approach in your country?
Thank you, Dr. Pang. We also approach in a similar way. So we explain all the risk, intraoperative and post-operative risk, including mechanical ventilation, tracheostomy. Many times we find the parents are very young and they are very difficult to understand the gravity of the situations. So sometimes we may require counseling not at once. Sometimes we may require twice or thrice counseling. So they will have a lot of doubts about this their kid. If they are not able to understand first or second time, we may request them to bring some of these relatives or friends who understand in a better way. We explain to them this surgery is the only major options left for the child, because other options like radiotherapy or gamma knife does not work in these patients. So to make them understand, they always have a doubt whether surgery is the only option or any other modality of treatment is available. That is their main anxiety in these kind of patients.
How about you, Dr. Lanyon? How is it in the UK with regards to counseling for major neurosurgical procedures for pediatric patients?
Well, I think along the lines of what's been said already, there is two parts to it. One is conveying information about expectations on how their child is going to look post-operatively and what the expected post-operative course and outcome for the patient is, as well as a conveyance of risk. And that's conveyance of risk is probably something that has changed recently in the UK, and that there's new guidance from the General Medical Council where we would be obliged to discuss the risk of serious complications, including death in a child such as this. So we would explore those risks with the parents and discuss with them the likelihood of those occurring, as well as the measures which we would be taking to try and avoid that. But the genesis of what we're trying to do is much along the lines of what's been discussed previously.
Dr. Fang, what are the potential differences between evaluating a neuro child versus a child who is well for general surgery? What are the differences?
The main issue with patients that having neurosurgical problem, we always ask whether patient have raised ICP symptom. Even after the VP shunt has been inserted, you need to make sure that there's no raised ICP, because sometimes the shunt has failed or blocked and need to be revised. So need to be repeatedly asked whether patients still have vomiting or any sign of raised ICP like headache, unwell. The other thing would like to ask whether they're having seizure and whether on any anti-epileptic medication, but because you need to continue the medication. And dexamethasone, whether patient is on, as this drugs sometimes will be started to reduce the edema that's surrounding the tumor. So all this medication has to be continued intraoperatively. The other thing I would like to ask the parents whether they have any, whether this polyuric pertaining to central diabetes insipidus, but posterior fossa tumor, unlikely they will have DI. Usually it happens in suprasellar tumor or cradopharyngioma. So how about you, Dr. Manikandan?
So our concern in this child is many of these children, they don't eat in the properly because of the disease process, because the tumor is located in the 4th or the 4th ventricle. they have persistent vomiting because it's close to the vomiting center. So they may be dehydrated, they may have a lot of electrolyte imbalance, they may be very hypotensive also. Then we have a lot of airway related concerns which can happen because it's located in the posterior fossa. So there can be difficulty in movement of the neck. Patient can hold the neck tightly because of the pain and other issues. Again, the problem with the surgery is involves in the prone position. Surgeon will keep the patient head higher than the heart level. So there is a risk of venous air embolism. Sometimes we ask whether the patient have any coexisting cardiac problems. If they have, then we will try to evaluate further by a cardiologist whether they have a patent foramen valve or any shunt lesions. So these are some of the major issues which to be managed in the perioperative period.
Any other input? I'm sorry. Any other input, Dr. Lanyon?
Well, I think along the lines of what's been discussed, it very much depends on the time course which the child has come forward for surgery. Some of these children can present quite early, but some of them can present quite late, particularly at the moment with the pandemic we're seeing. If it's quite a late presentation, there may be cranial nerve involvement, and potentially there's a risk the child has been aspirating chronically. But many of these children have quite an isolated condition. So a general assessment of their health status, and then an assessment of the severity of their tumour and any raised ICP is pretty much the basis of what we will perform.
Dr. Fang, in one of your slides, you have shown that this surgery was done the patient is in a prone position. So what are your considerations with regards to putting this patient in a prone position? Are there any concerns regarding that position?
Yes, in my institution, usually patient will put prone on horseshoe. Eye is being pat and shoulders and the chest is being put a shoulder robe underneath to wide pressure saw. And because we usually do the case with head and towards the surgeon is 180 degree to the GA machine. So we need a long tubing to ventilate the patients. There's a concern of a lot of dead space, and probably I need a higher gas flow to wash out the CO2. How about Dr. Manikandan? Do you usually do in a similar way or in different ways?
In our center, we put the patients on pins. So with head pins, all the patients are positioned. We generally use a flexor metallic endotracheal tube because many times the surgeon would like to flex the neck for the sake of access to the fourth ventricle. So there is a high risk of kinking of endotracheal tube and increasing airway pressure if we use PVC tubes. So that we should be very much careful. Similarly, we have long extension lines for airway circuits as well as the intravenous lines as well as the central lines. So we keep around the 3 meter circuits. We keep our anesthesia machine at the foot end of the operating table, whereas the surgeon will be standing at the head end of the table.
Dr. Lanyon, how about in the UK?
So
what are your concerns?
Yeah, I would say our experience is probably fairly similar to Dr. Manikandan. We have the anaesthetic machine at the foot of the patient. We use a long circle circuit, and we have a backup AST piece with a long extension on it too, for in case of emergencies. In terms of concerns of positioning, we often use a horseshoe on the smaller patients, but after they are older and ossify, we would then use pins. Our particular concerns are getting sterile surgical prep in the patient's eyes, and so the eyes are padded and the face is covered as part of the surgery. And we also prefer to use a reinforced tube as well to avoid the risk of kinking. In many of the patients, though, if there is a plan to go to ICU post-operatively, we would place a standard ET tube at the start of the case. But for any extreme positioning of the neck, we would normally place a reinforced tube.
Okay, thank you for that input. Dr. Fang, do you normally put a central line for these kinds of patients?
Yeah, in my institution, we usually put femoral central line for major neurosurgical surgery. It's for inotropic support, for IV access, resuscitation, and to facilitate the ward, because usually there will this kind of patient will stay in a hospital quite some time, and usually end up with difficulty in having IV access. So usually it depends on the weight and age of the patient. For 1-year-old kid, probably I will use 5 French double lumen, 13 cm 5 French for femoral line. I'll try to avoid the neckline because patient having VP shunt inside too, and also we reserve the intrajugular access for VA shunt, ventricular atrial shunt. In the case of repeated the shunt needs to be revised and need to convert the VP shunt to VA shunt. How about Dr. Manikandan? What's your practice?
I agree with you, Dr. Fang. Many times it is these children will have very difficult IV access because they have been having prolonged hospitalization and multiple hospitals. They go and they come to our institute. So we require a wide bore intravenous line. If possible, we take 1 or 2 wide bore intravenous line because these tumors are highly vascular. And as you see this scan, this is quite a big tumor for this small child. Again, regarding the central line, we also insert central line. We don't insert in the femoral line, we use internal jugular vein. We find it more comfortable using internal jugular vein. If the patient is not having preoperative shunts, we use IJV, otherwise we use a femoral line if the patient is having a shunt. So we put long extensions, we take the lines along the side of the patient. So there is always some kind of risk of kinking of the CVP is always, central lines. So after positioning of the patient, we aspirate there is adequate blood flow, backflow is available in all these 3 ligaments. That's why we confirm it. If there is any reduced backflow, we tell the surgeon to readjust the pins and head position so that we ensure that internal jugular vein is not kinked. So there is adequate blood flow is present in all the ligaments.
How about in the UK? What is your practice, Dr. Lanyon?
Well, I think for us, the reasons for inserting intravenous access is twofold. One, to ensure adequate access for volume resuscitation, and secondly, for the administration of drugs. In terms of establishing that, it depends on what access is available for the patient. So if you can establish a large bore cannulae in a saphenous vein and a second cannulae as a backup, we would routinely not place a central line. If we were unable to do that, we would often place a femoral central line, or if the patient has been in previously, we often see they have either a tunneled CVC or a PIC, and so that would be the access that we would use.
Okay, thank you. This is a very complex procedure and very sick patient at that. How do you do this patient and how do you give anesthesia? Dr. Fang?
If patient comes with the IV access, our usual practice is to use fentanyl, 1 to 2 mic per kilo, propofol, 3 to 4, titrating dose according to the BP heart rate. And if hemodynamically unstable, probably I will use ketamine. But usually, this kind of patient, because it's elective surgery, usually this patient will be well resuscitated before coming for surgery. So fentanyl, propofol, atracurium or rocuronium. If there's no IV access, or the IV access is very difficult, I probably will titrate sevoflurane, gas inhalation, start with 2%, then titrate up until patient is asleep. Just be careful with it, because MAC of more than 1, the sevoflurane actually can increase the cerebral blood flow and can increase the ICP. How about you, Dr. Manikandan?
Yeah, thank you. Separation of the patient from the parent is one of the real problem. And second is IV access is another major issue and it's very challenging for the neuroanesthesiologist. So if the patient is in altered sensorium, majority of the posterior fossa tumor, they may be in altered sensorium or they're obtunded a little bit. So it will be a little easy for us to separate from the parents. However, if the patient is fully conscious, it may be very difficult. So generally, we don't give any pre-medication. because of the concerns of respiratory depression or monitoring of the patients. So it is a real challenge to induce these patients. If the child is having already a intravenous line in place, then we use intravenous induction agent. Usually we give either thiopentone with the fentanyl because we don't have a remifentanil. So we give thiopentone fentanyl with the vecuronium. If there is no IV access, we use sevoflurane induction. We gradually, as you already informed, there is a real concern for raising intracranial pressure and the risk for seizures following sudden high dose of sevoflurane. We start with around 3% and gradually increase to 5 to 7% till the patient loses consciousness. That's how we manage our induction.
How about in the UK, Dr. Lanyon?
So I think
Is there
a
any
lot-
preference to TIVA or inhalational induction?
I would say in terms of induction, generally the preference for this type of case would be to do an intravenous induction if it was possible. But that is tempered by the same considerations, and that if IV access is expected to be difficult or the child is very upset, we would default back to an inhalational induction. We would be more happy to use pre-medication in these children. It's not infrequent for a child such as this who's already had multiple anaesthetics as part of the diagnostic process to have a midazolam pre-med, and we would usually invite the parents to come in for the induction in our anaesthetic room until the child loses consciousness. But a similar graduated use of sevoflurane would be our usual practice for the same consideration of raised ICP.
How about the use of Presidex, Dr. Fan? Is this being used in your country for induction of anesthesia?
Yeah, I regularly use dexmedetomidine in airway surgery, tonsillectomies, patient with OSA, patient with anticipate having emergency delirium post-operatively, but I don't usually use Presidex for neurosurgical patient. The reason is usually in my institution, most of the neurosurgical patient will be ventilated post-op at least for 1 to 2 days for CT scan or MRI or for cerebral protection. The only time I would want to use dexmedetomidine if I want to extubate the patient in the theater or extubate immediately in ICU. How about Dr. Manikandan? Do you use Presidex in your country?
We don't use it intraoperatively in pediatric patient in neurosurgery. However, we use this for a sedation in MRI or short procedures which the child may require. So the patient will have to give anesthesia for MRI procedure in the preoperative. We generally give dexmedetomidine infusion during the procedure. Otherwise, intraoperatively, we generally don't use it. We use with the propofol fentanyl infusion is our standard practice.
Is there room for Presidex in the UK for induction of neurosurgical patients, Dr. Lanyon?
I would say that Presidex or dexmedetomidine is uncommonly used in neurosurgical procedures in the UK, for children at least. We certainly use a lot of it as a pre-medication, so intranasally 2 to 4 micrograms per kilo up to a maximum of 200 micrograms. And similarly for sedation in imaging procedures such as MRIs, but it's uncommon to use it intraoperatively because of concerns about bradycardia associated with its use. So it's not something I've seen in the neurosurgical theatre, although I do think it is something that is expanding in its use.
Okay, thank you for that. How about Dr. Fang? What are your thoughts about TIVA versus sevoflurane for this infant?
For this child, I will use inhalational as my maintenance of anesthesia. For bigger kid, I will use TIVA because propofol infusion can help to reduce the cerebral metabolic rate. Because there's concern of remifentanil causing bradycardia, and sometimes I feel that propofol on top of remifentanil, especially in infant, it tends to have bradycardia more than in older children. So I use TIVA for older children. For infants, I will use inhalational. How about Dr. Manikandan?
Our practice few years ago was totally sevoflurane was the primary choice of anesthetic agent in pediatric patients. However, last 4 to 5 years, we have been using a lot of intraoperative neuromonitoring techniques like brainstem auditory evok potentials, and surgeon would like to stimulate various cranial, lower cranial nerves. So we use the intraoperative neuromonitoring of late a lot. So my practice has changed from sevoflurane to Tiva. We usually use propofol with fentanyl infusion. We don't give muscle relaxants. So we give relaxants only at the time of induction. So rest of the time we manage only with the Tiva based techniques because of a lot of use of neuro monitoring intraoperative nowadays.
What are your thoughts, Dr. Lanyon, on this?
So I would say that most cases in the UK for major neurosurgery such as this would use a remifentanil infusion as the background analgesia during the case. It's very variable as to what is used in inhalational versus TIVA-based technique, but certainly the TIVA will be based on propofol at our institution. So the majority of cases such as this we would do on a propofol remifentanil combination, although I do know some of the other centres I've been involved with would do this as a sevoflurane and remifentanil case. So I think there's a lot of variability, and definitely when you get to the younger children, you tend to lean towards the sevoflurane.
Okay. How about the choice of fluids, Dr. Fang? Is there, what are your thoughts on that?
I usually will start off with crystalloids. I try to avoid colloids as far as possible because I believe for neurosurgical, during the neurosurgery, there's a concern of breach of the brain barrier. The colloids actually can cross the brain barrier, causing more edema. So crystalloid, I will start off with stirofundin. We have it in Malaysia on a normal saline, and I will regularly do the dextrose monitoring, make sure it's not hypoglycemia. Once there's a downward trend of sugar level, I will start some dextrose containing solution. So for blood loss, and if the hemodynamic unstable, blood loss reaching 25% or tachycardic or hypotension, I will start blood transfusion. And if there's a 50 to 100% of the blood volume loss, I will probably start plasma or platelet or cryoprecipitate transfusion. How about you, Dr. Manikandan? Well, just to add on that, we don't have a TEG in our institution, so it's mainly based on the blood loss, and we will start transfuse of blood products if more than 50% blood volume loss.
So we start with usually a normal saline infusion, and then we frequently check the blood sugar, usually hourly blood sugar monitoring by point of care devices. As you told that if the patient's blood sugar is too low, below 80 milligrams per cent, we generally supplement with the glucose containing solutions. Otherwise, we don't routinely give glucose because majority of the surgery finishes within 3 to 4 hours. With regard to, we also don't give colloids in our practice. With regard to blood transfusion, again, as I told you, we have TEG, but we don't routinely use in the intraoperative period. Suppose the patient is bleeding in the postoperative period. If there is coagulopathy, we generally do TEG. Otherwise, for intraoperative blood replacement, we use point of care devices like hemoglobin monitoring, as well as we have PT and INR. We routinely follow this. As he told that if there is hemodynamic instability, more than 20% change occurs, or there is a lot of blood loss. As you know that this surgery is done in prone position, the tumor is large and vascular, and there is a lot of venous channels will be engulfed because this tumor is located in the posterior fossa. There can be compression of all the venous sinus. When surgeon opens, there can be enormous amount of blood will be lost at the time of opening the bone and neuro as well. So we have to be highly cautious and vigilant. If there is any blood loss occurs at the time, we immediately start the blood and blood products. This is our usual practice.
In the UK, Dr. Lanyon, what is your choice of fluids?
So I would say at our institution, typically Plasmolite would be our usual induction fluid and maintenance fluid. And then it varies in practice as to whether it's a glucose infusion of 10% glucose titrated to the glucose on the ABG or just intermittent boluses of glucose, and that's very practitioner dependent. We have similar sort of management of blood loss in that we're quite happy to give red cells on their own up until a point, but then we would usually be guided by either ROTEM or TEG to decide what products we're going to give and in what amounts going forward from there. The caveat of that being exactly as Dr. Kundan has expressed, that if there is sudden blood loss, we would usually call for blood at that point and replace blood with blood until control is established.
Normally, cases like this really take a long time for the procedure to be finished. So, do you extubate these patients or do you not, Dr. Fang?
At the end of the surgery, I will communicate with the surgeon what's their concern and what's their preference. For big tumor case, most likely patient will need to be ventilated and cerebral protected for at least a day. And next day, they need to go for CT scan or MRI. The problem is we don't have intraoperative CT scan or MRI in our institution. So need to be ventilated, and the next day will be sent down to the CT scan room for imaging. So usually patient will post-operatively being sedated with morphine overnight and reassess by using the imaging and decided whether it can be extubated. But if the tumor is small and hemodynamic is stable, and there's no concern of brainstem damage and patient is breathing regularly, probably can extubate immediately next day. How about you, Dr. Manikandan?
So I also agree with Dr. Fang on that. In addition to that, if the children receive a lot of blood loss, if the kid is having hypothermia at the end of the procedure, after turning the patient from prone to supine, we find that a lot of airway edema, tongue edema is there. We generally don't extubate those patients. We generally allow the airway edema to come down. In addition, we routinely perform postoperative CT. Most of these children, they may have complications like pneumocephalus can be there. So it is better to have a postoperative CT, or it can be a hematoma or extradural hematoma because of a lot of vascular channels present in the posterior fossa. So we do a routine postoperative CT, and then we plan if the patient CT is all right and there is no airway edema and the patient is warm and the fluid, electrolytes and hemoglobin is comes to the normal or baseline. So then we plan for extubation electively. Otherwise, if there is a complication, we tend to ventilate overnight by giving sedation of either dexmedetomidine or propofol infusion, and we plan for elective ventilation.
There was this mention of tracheomalacia in the history. Would that be a problem in deciding whether to extubate or not after the surgery? What are your thoughts on this, Dr. Lanyon?
Well, I would say, first of all, our primary practice would probably be to try and extubate these patients' day of surgery, but it's very much dependent on the progression of the case and the background history of the case. If this child had a history of tracheomalacia but was out in the community breathing normally with no supports at all, I wouldn't see that as a contraindication to attempt extubation, but I would have that in the back of my mind as a note of caution. If the child is someone who's dependent on extra supports, extra oxygen in the community, then that changes the complexion of the case and makes it more likely for me to keep the patient intubated in ICU. But I think the overall decision is a discussion between the anaesthetist and the surgeon based on the best interests of the child. We're fortunate that we have MRI available in our operating suite, although not in our neuro theatre. And so typically we would roll the patient back supine, transfer to MRI and perform a post-operative MRI and then wake the patient up. And that often allows time for some of that initial swelling to go down. But it's a discussion based on the procedure and the progress of the patient. Okay,
thank you. Dr. Fang, one of the common complications of this kind of procedure is a venous air embolism. Is this something that you experienced already in your institution?
I only seen once venous air embolism in my career. And that's is because it's prone position with a bit of head up. In our institution, we don't usually prone with the head up, so I hardly seen venous air embolism. But I always tell my trainee when do any case of neurosurgical with prone position, you need to look very hard at the end tidal CO2. Once patient is tachycardic and there's a sudden drop of end tidal CO2, always think of venous air embolism and until proven otherwise. So if it's that happen, so you want to alert the surgeon, ask them to flush the operative field and then ready to be unprone for resuscitation. And bear in mind that always need to keep patient euvolemic. So need to give adequate fluids is just to make sure the air will not suck in if the CVP is low. We don't have a transesophageal echogram. We don't have a precordial stethoscope to detect the VAE. So it's just based on clinical. How about you, Dr. Manikandan?
Yeah, Dr. Pang, we also don't have advanced monitoring like transesophageal echocardiogram or precordial Doppler. We still rely on the end-tidal carbon dioxide levels as a prime modality for monitoring for venous air embolism. Unfortunately, we see quite a bit of number of patients because we operate a lot of pediatric patients in our practice, and our surgeon likes to keep the head above the heart. So we see quite often the venous air embolism as a complications. Moreover, there is a lot of venous channels, as I already told you. When the surgeon opens the skull and there is a lot of venous channels, especially dilated veins over the dura, there is a risk of venous air embolism is quite almost like 20 to 30%, as written in the literature. So we have to be highly vigilant. As you told that our management issue also will be similar to that. We give a lot of intravenous fluids, and if there is severe hemodynamic instability in the form of severe bradycardia or severe hypotension, we use inotropes or vasopressors to tide over the crisis. And we inform the surgeon as soon as the problem occurs. And we try to put the head a little lower than the heart, and the surgeon will flush the field with saline and try to find out any rent is there and try to seal whatever is bleeding or whatever the open channels.
How about you, Dr. Lanyon? How do you prepare your patient to avoid venous air embolism from happening?
Well, management will be much the same as what's been described. We also don't use precordial Doppler or any other advanced monitoring for this. We also rely on the CO2 and clinical judgment. And as Dr. Kundan has said, the surgeons will often know if they've opened a large vessel and be able to give you warning to be extra alert from it at those times. But maintaining normovolemia to slightly full of the patient's volume status as a preventative measure is the mainstay of what we would do. And then the management, should it occur, as much as is being described.
Okay, thank you for all your inputs. This will definitely be very useful for our audience. Hopefully,
Yes.
this will improve our practice.
Yes, everyone. Thank you so much for the very interesting discussion. Hi, everybody. So welcome to the Q&A section. We do have a couple of questions. Dr. Geraldine, if I could just get you to start off with the first one.
Okay, thank you, Dr. Koo. We have quite a number of questions sent through the chat box. And the first question is actually directed to Dr. Manikandan. So the first question goes, is there a lower age limit that you will use TIVA for? Or regardless of age, will you use TIVA for all children?
So, we generally use TIVA above the age of 1 year because, as I already told you, we are using a lot of neuro monitoring. So, below the age of 1 year, it may be very difficult to interpret the neuro monitoring. So, we use sevoflurane as the maintenance for children below 1 year. More than 1 year, we commonly prefer to use TIVA based technique.
Okay. Do you usually titrate your TIVA based on hemodynamics or based on EEG guidance, such as the BIS monitor, to aid in the titration of TIVA? That's the follow-up question.
Yeah, we use bispectral index in all our patients whenever we are using PIVA based anesthesia technique. For monitoring, successful monitoring of cranial nerves or spinal cord or brainstem, you require a steady state anesthesia concentration. So if there is any change in the evoke potential, we should correlate whether there is a change in the anesthetic depth or not. For that reason, we generally use the bispectral index. We don't use this bispectral index for early extubation as more Frank told, or in our practice also, we generally tend to ventilate the patient post-operatively. Once the patient is hemodynamically stable and the CT scan is normal, then only we plan for extubation. So the main purpose of using bispectral index is to maintain a steady anesthetic concentration in the intraoperative period.
Okay, thank you for your responses. Dr. Ku?
Oh, if I may chip in, well, in our institution, we have recently used the set line in the last 2 years. So the set line shows an EEG and it shows what we call a 3D spectrometry with the color patterns that relate to either the drug that you're using, sevoflurane, or TIVA. I think my purpose of using depth of anesthesia monitoring in these sort of cases, especially for a kid who is 8 months, you're right. It's not about the purpose of early extubation. It's about maintaining a stable anesthetic. And also, in the case of hypotension, if it's due to excessive anesthesia, I will be able to tell that. And so that helps me to regulate the blood pressure without the overuse of fluids or vasopressors.
Okay, thank you for that response.
Dr. Lanyon, did you have something you want to say?
No, sorry, that was fine. No.
Okay. Well, Dr. Manikandan, actually, you did mention the use of Presidex in sedation for MRI. We do have a question from one of the audience. What is your usual doses of Presidex that you use for sedation?
We have, before the starting of MRI, we usually give a loading dose for 10 minutes, usually 0.5 microgram per kg per over 10 minutes. Followed by we give an infusion of usually 0.2 to 0.5 microgram per kg per hour. So we will put the patient to sleep. We don't keep too deep sedation. This is some
Right.
kind of sedation score we commonly use.
I see. Okay. Well, thank you very much. The other question that we have is with regard to post-operative management. So, as we have seen from the pain plenary this morning, quite a number of untreated post-operative pain, and especially so in neuro anesthesia, where we are worried that opioids may obtain the neurological response. So, Dr. Pang, if I can just invite you to tell us a little bit about what your institution does in terms of post-op pain management.
All right, in my institutions, there's two group of neurosurgical patients. One patient is ready to be extubated, and one group of patients, especially patients that have big tumor and surgeons want to be ventilated in ICU and proceed with imaging the next day. So the patient that ready to be extubated, usually a tumor cases, which is very, very small, or craniosynostosis. So I do find that if one extubate neurosurgical patient, best is to put on patient on TIVA, because I often encounter many neurosurgical patients having very bad emergency delirium after giving inhalational anesthetic as a maintenance of anesthesia. So if I'm not using TIVA, if I'm using inhalation, usually at the end of the surgery or at the mid-surgery, I will probably give some ibuprofen, 1 to 2 mic per kilo. That is not only for the pain, and also it's for the emergency delirium. On top of that, I give
0.2 milligram per kilo of morphine intra-op. So with post-operative morphine infusion for neurosurgical patient, I am will be very extremely careful of it, because neurosurgical patients tend to be opioid naive. And if you send back patient with IVI morphine in the ward and the nurses are not vigilant and not taking care of the patient, somehow they will go to respiratory arrest and can be very bad, the consequences. So usually if patient on IVI morphine, I usually request to be nursed in high dependency ward. Or the other option is I will put on patient on multimodal analgesia and say, if not bleeding from the drain, paracetamol and syrup morphine. The other group of patient where the patient have major tumor and need to be ventilated post operatively at least 1 to 2 days. Usually by second day, when they are being extubated, I find that the pain score is not too bad, and usually they are quite pain-free on paracetamol and syrup morphine. That's my answer.
Right. Dr. Nicholas, I understand that you may have a slightly different practice in your institution.
So I think the basis of what we would do is very similar to what's been discussed. We would often have a background of paracetamol and potentially, depending on the case, a COX selective non-steroidal. But then we would often use what we call nurse-controlled analgesia. So it's very similar to patient-controlled analgesia that many of you will be familiar with from your adult practice, with pumps set up with regulated timings in terms of pressing. But instead of giving the patient, which in these age groups may not be able to operate one of these pumps or may not be able to operate a pump in the context of recent neurosurgery, we give this control to the nurses. And so typically it will be a bolus once every 20 minutes with a background infusion of around 0.2 to 0.5 milligram per kilogram per hour to try and give the nurses a way of giving rapid bolus analgesia, particularly in a child who may have probable vomiting.
Right. Well, thank you very much for your inputs with regard to this Q&A, but we are out of time, unfortunately. So let's move on to our second case discussion. I would now like to hand over the time to Dr. Nicholas Lanyon for our second case discussion. Over to you, Dr. Lanyon.
Thank you, Dr. Truss. Our second case is going to revolve around discussion of a paediatric traumatic brain injury. This is a case that occurred here in Glasgow and involved a 10-year-old male of approximately 30 kilograms in weight who had head trauma versus a passing train. The child was at a station and was running alongside the train on the platform when they tripped and fell. They were struck in the head by the protruding steps of the train, rolled over, and then struck a second time by a second set of steps of the same train. They came to rest face up on the platform with an apparently isolated head injury. When the initial assessment was performed at the scene by the ambulance crew, the child had a GCS of 3, which improved to 5 during the time of their care, heart rate of 120, and a blood pressure of 110 on 65. They had a sluggish right pupil with an obvious depressed skull fracture, but no other injuries that were evident to any other part of their body. Given the proximity of the local hospital, the ambulance elected to perform a scoop and run rather than perform any prolonged resuscitation at the scene. I'd now like the rest of the panel to join me and we'll have a discussion regarding the management of this case. So, in terms of this case, the initial arrival of the patient into the trauma department involved a resuscitation, and assuming that the facts that we know so far are evident that there's no other separate injury to any other part of the body other than the isolated head injury that we know about, the emergency department may request anaesthetic assistance with initial induction and intubation of this patient. I'd like to ask Dr. Pang, if you were called to such a situation, what your initial approach would be to the induction and management of the airway?
Presume that patient will be on cervical collar because it involve a head injury, usually they will have associated cervical injury. So the problem with if patient on cervical collar, you must need to maintain the position using the manual inline intubation, if not intubating via video laryngoscope. The problem down in our institution, down in ED, we don't have video laryngoscope. So usually they will intubate using a fentanyl, ketamine, rocuronium, if not intubating with succinylcholine. If they fail to intubate, they usually call for help from anesthetist, and we will run down with video laryngoscope. And we usually will intubate with cup tube to avoid leak when being ventilated in PICU, and also to reduce the change of ETT if a plain tube is being used. So how about you, Dr. Q? What's your practice in your institution?
Pretty much similar to yours. I'm only called down when they have trouble intubating, and I would come with my video laryngoscope with MILS, manual inline stabilization, and the use of the video laryngoscope to minimize neck manipulation. We are quite fortunate here. We do have microcuff tubes, and that will be my tube of choice.
Dr. Geraldine, can I ask what your practice would be in the Philippines?
Well, in the Philippines, we'll be doing the same. But of course, other than that, one thing that is also good to mention is that we need to check on the hemodynamic status of the patient. If we have to give the proper resuscitation just before we give the anesthetic for intubation. So practically the same, but added more on the hemodynamics of the patient.
I think that's probably a very wise suggestion. A crystalloid bolus prior to induction definitely is something that could be quite useful in these children. I might stick with you, Dr. Geraldine, and ask you, we're talking about hemodynamics. What sort of targets would you be aiming for in ED? What are your goals in terms of the patient's vital signs and the patient's CO2 once you've intubated?
Of course, we're given this patient with a depressed level of consciousness, and we assume that patient is hypoventilating, so there could be accumulation of carbon dioxide. So therefore, given that this is a traumatic brain injured patient, we might as well address this issue by doing hyperventilation up to a targeted end tidal CO2 of around 30 to 35. So we have to be careful in doing that because from what we understand from the cerebral perfusion pressure, mean arterial pressure minus ICP is will determine your CPP. So therefore, we have to maintain a certain mean arterial pressure to overcome the increase in ICP brought about by the traumatic brain injury. But of course, it all depends on how we receive the patient, and we do not want to aggravate the patient's condition. So we will address the issues as they come.
Dr. Charis, your practice in Singapore, what sort of numbers would you be targeting?
So I'll be looking at an age-appropriate map, but in this case, I'm concerned that there's raised ICP for this patient, especially since he had quite 2 bashes to the brain and what looks like uneven pupils. So I'll be looking at bumping up the map in order to maintain CPP. And I would probably say I would plus 20 to that. So in the event that I don't have a vasopressor yet, I would be looking at hyperventilating the patient to about 30 to 35 EtCO2 while preparing the inotropes.
And Dr. Pang, your management?
Almost the same as Dr. Koo. Just to add on the cerebral perfusion pressure, I will be maintaining around 40 to 50, 40 for infant, bigger kids will be 50. So for this patient, I will aim CPP around 50. So based on the sign and symptom and the clinical history, they probably have increased ICP. I would assume more than 15 because of unequal pupil. So yeah, with the CPP plus another 15 millimeter mercury of the ICP, that will be around 65 MAP for this patient.
So it sounds like as a group, we're targeting a higher than normal mean arterial pressure to try and maintain that cerebral perfusion pressure, as well as utilizing carbon dioxide, reducing the levels in the bloodstream to try and maintain the intracranial pressure as low as possible. I might stay with you, Dr. Pang, and just ask, to control this, the mean arterial pressure, once you've given fluid and volume resuscitation appropriate to the amount of blood loss, what vasopressor agent would you use to try and achieve a supernormal blood pressure?
Usually, patient will be resuscitated using a peripheral line. It's quite difficult to get central line when patient is hypovolemia. So the first choice will be diluted dopamine. And if the blood pressure is down the floor with bradycardia, probably diluted adrenaline. If there's a central line, so my choice will be no adrenaline.
Okay. And Dr. Charis, does it differ in Singapore?
Well, in Singapore, the first choice is diluted dopamine if there is a peripheral line. It is quite difficult to set a central line in the ICU, and I don't think they have the kit for CBP also. So most of the time it is diluted dopamine via a peripheral line to keep the heart rate up as well as squeeze the blood vessels.
Dr. Geraldine, your practice in the Philippines?
Yes, it will be practically the same. We'll start off with dopamine because of the increase in heart rate brought about by dopamine. That would actually increase the cardiac output and therefore improve the mean arterial pressure, which is one of our goals in acutely addressing the problem of this patient.
So it's interesting hearing that. Here we would tend to use phenylephrine as our initial agent and then move to dilute adrenaline, particularly if there was a concern about the heart rate. But then noradrenaline would become our prime agent once central venous access is established, much as Dr. Pang has described herself. So thinking about this patient, we've now stabilized them with an initial resuscitation, intubated them, controlled the airway, and done some initial measures to control both the cerebral perfusion pressure and the intracranial pressure. But probably the next step is that we're going to be heading towards the CT scan and onwards from there potentially to the operating theatre. What equipment would you be thinking of in terms of this move, Dr. Charis, in terms of planning for getting there, both in terms of monitoring equipment and management equipment in terms of pumps and ventilation?
Mm-hmm. So I like to sort of divide it. I say patient, transport equipment, route, and personnel. So if you were asking about what sort of monitoring I would have, in addition to our standard ASA monitoring, I would add on ETCO2 just to make sure that the ICP is under control. Here we're quite fortunate. We do have a little portable monitor called an EMMA. It's an inline little box that gives you both the respiratory rate as well as the ETCO2. And if we do have the Philips monitor with us, there is a side stream ETCO2 monitor. But I understand that it may not be available in all institutions.
Dr. Pang, what would your practice be?
Almost the same as Dr. Koo, except that we don't have a portable end-tidal CO2. So what usually the ED physician will do, that they will take a baseline gases when they put on a portable ventilator. And when they have achieved the partial arterial pressure, CO2 at a target level of 35 to 40, they will send to the CT scan with that that setup of a ventilator setting based on the ABG results.
And Dr. Geraldine in the Philippines.
Yes, since we don't have the available end-tidal CO2 in the ED, then we actually do the same and base our ventilation of the patient on point of care determination of arterial blood gas and be guided accordingly.
So I think we're all quite concerned about what the CO2 level is, and it doesn't matter what the institution is or what the resources are, but we're trying to make sure we control that at the level we want for this patient at the time. You arrive in the CT scanner. I mean, we're quite fortunate that we have an anaesthetic machine in our CT scanner, but it's not always turned on and it's not always in working order at the time that cases like this come in. What would your practice be, Dr. Geraldine, in terms of how would you ventilate this patient whilst they're undergoing the CT scan?
You mentioned there's a anesthesia machine, right?
Well, I'm interested to know what you do in your practice, because for us it's very variable depending on the time of day and what is available.
Okay, so since this is an emergency situation, we have to ask for help and have this prepared in the CT. So, of course, we'll have to look for the anesthesia machine if it's available in the area. If not, we have to ventilate the patient with using a Jackson Reese and an alternative oxygen source. So definitely we will find ways in properly ventilating this patient as being fit.
So you would have a member of staff don lead and have a Jackson Reese circuit during the procedure, which is very similar actually what we would do for a patient requiring breath holds. Dr. Payne, can I ask what your practice would be?
We don't have a J machine that is freely available in a CT scan room. Usually the patient will be transported from the ED to the CT scan using the same portable ventilator. The CT scan usually lasts less than 5 minutes. So they will transport the patient with the portable ventilator to be put on the CT bed. If the portable ventilator is not available, they will manually back with the not the Jackson Reese, because they are not being trained to use that, but they amble back by using manual bagging.
Okay, and Dr. Q in Singapore, can I ask what the practice is?
Well, we do have an anesthesia machine that is stationed in the CT room, and we do use that with a long circuit. However, in the case of no ventilator available, I would opt for the use of the TPs with a portable oxygen tank, and to keep the patient asleep, continue on a propofol infusion. I guess this is where also the paralysis and sedation is important. He may be GCS5, but there might be still ventilator dysynchrony, or there might still be some sort of struggling that can increase ICP.
And certainly you're right, you're expecting pain, you're expecting some amount of respiratory effort with this, and none of those are helpful for intracranial pressure. So running some sort of sedation and some sort of paralysis can be helpful to gain control. So in this patient CT scan, what was found was very much what was expected in the initial thing. The patient had a significant depressed open skull fracture over the superior sagittal sinus, and that was actually appeared to be involved in the actual bone fragments at the time. There was a significant amount of fragmented skull tissue that was in that depressed area and extending into the brain, and the patient proceeded directly to theatre. Obviously with this, there'd be some ongoing ooze at the time and some blood loss at the scene. And I'm interested to see what the panel thinks the role of tranexamic acid would be in this case. And Dr. Q, I might stick with you and have you start.
Mm-hmm. So it is part of our standard ED protocol that when the patient lands, if it's a trauma patient, they get tranexamic acid 10 mg per kg, single shot. Yeah.
And would you continue an infusion after that, or just a single dose?
Actually, in theatre, our practice is slightly different. We run everything via infusion. So 10 mg per kg goes into the patient via an infusion over 1 hour, and we maintain an infusion of 2.5 mg per kg per hour thereafter until we are quite convinced that the oozing or the bleeding is under control.
And Dr. Geraldine, your practice?
Yes, we do give tranexamic acid, but we only give it in the beginning and over 15 to 30 minutes of 10 milligram per kilogram IV.
Okay. And Dr. Pang, the practice in Malaysia?
It's not a usual practice to give tranexamic acid in the ED, but if the patient come to theatre and I find if the tranexamic acid is not given earlier, I would give a dose of 15 milligram per kilo. And if the CT shows there's ongoing bleeding, probably I'll put on infusion of 5 milligram per kilo per hour.
It's interesting seeing the differences around the place of doses that are used. We typically would give 15 milligrams per kilo over 20 minutes. And that's often given actually at the roadside by the ambulance service now. And then in theatre, continue at 2 milligrams per kilogram per hour for the duration of the case. So clearly an evolving area of practice in terms of finding the dose to go there. So we have talked about bleeding, and I suppose the next natural evolution is around what blood product management you would utilise. And there's all this discussion around what ratio you should start and when you should start giving alternative clotting factors. And again, I think there's quite a lot of difference around the world. So, and Dr. Pang, in this case, what would your approach be to blood product management for this child?
Ideally, there should be a massive transfusion protocol to deal with the major hemorrhage in neurosurgical patient, but our institution, we don't have massive transfusion protocols. So if there's ongoing blood loss and the blood loss has approaching 50% of the blood volume, I would start giving red cells and ordering 20 mL per kilo of plasma, fresh frozen plasma. If the bleeding is still not stopped, another 10 mL per kilo of platelet and 10 mL per kilo of cryoprecipitate. We don't have fibrinogen concentrate in our hospital. We do have Novo 7, but I have never given before in neurosurgical patient. But I have personally given to surgical laparotomy patient with 90 mic per kilo of Novo 7, but end up patient having portal vein thrombosis. So as far as possible, I won't give replacement, a concentrate replacement to pediatric patients. So my first choice is still red cell and blood products.
Dr. Geraldine, do you have a different experience in terms of managing blood products?
Yes. Well, it depends on how young or the child is, or the dictum usually we follow is that once the patient starts bleeding, we must be starting off giving blood products already. So we start off with packed cells, and then once we've noticed that the blood loss is around 50%, then we start off giving fresh frozen plasma and platelets thereafter at 10 mL per kilogram IV each. But in the beginning, once the blood, there is active bleeding, we start off giving blood already. So that's how we do it in the Philippines.
And Dr. Koo, your practice?
Well, we do have massive transfusion protocols based on weight for our patients. And usually it consists of blood, platelets, and FFP. And only in perhaps the third wave does cryoprecipitate come. In cases where it has been quite dire straits in terms of, say, polytrauma, and the patient is bleeding despite every effort, We do have Novo 7 and we do have cryoprecipitate concentrates, Fibriga. Personally, I have not used Novo 7, but I've seen colleagues use it in a polytrauma situation. And it was given in 0.1 mg per kg. So a 30 kg child received 3 mg of Novo 7. For the fibrinogen concentrates, I have personally given them, and usually that is in about 70 mg per kg dose.
It's interesting seeing the differences throughout the world. We don't have access to the concentrated clotting products. And so similarly, we would have an initial wave of 1-to-1-to-1 red cells, plasma, and platelets, followed by cryoprecipitate at a later point. And then we would largely titrate that from there based on what the point of care testing, both in terms of ABG and TEG shows. But it would very much depend on the situations. I think you've said that if you have an in extremis situation of ongoing bleeding, that's a much more aggressive resuscitation than a gradual lose at the time. We spoke earlier about raised intracranial pressure and about managing that in terms of mean arterial pressure targets and end-tidal CO2. But I suppose what we haven't discussed is other agents for managing raised intracranial pressure. So mannitol and hypertonic saline are both commonly discussed about, but I'm interested to see what the differences in practice between the people of the panel are. So Dr. Pang, can I ask what you use and what your preferences are?
In our institution, pediatric ICU prefer to use hypertonic saline, 3%, bolus of 4 ml per kilo, and run at 1 to 2 ml per kilo. So usually, if the patients come straight to theatre without having to go to ICU, I will start with the bolus hypertonic saline first, and I put an arterial line and do regular blood gases and to look at the sodium level to make sure it's not less than 135 millimole of sodium level. About the hypoventilation to acutely reduce the ICP, if the brain is really bulged out and the surgeon has difficulty in accessing into the operative site, I will hypoventilate. But do remember that if I stop hyperventilate, there will be rebound ICP. So just to be aware of this.
Dr. Jose, can I ask your practice?
So basically, we normally use mannitol in the OR. One reason maybe because the neurosurgeons actually do prefer mannitol in the OR for some reason. But I guess eventually over time, hypertonic saline will be used also in the operating theater. But what the advantage of the hypertonic saline is that even if the patient is dehydrated, there won't be too much of a fluctuation in the hemodynamics of the patient, which will definitely be beneficial to the patient. So over time, I guess we need to coordinate with our neurosurgeon and discuss this matter so that it can be later on used in the operating theater.
And Dr. Charis, your practice in Singapore?
Well, mannitol is stocked in the theatres and 3% saline is stocked outside of the theatres.
Okay.
So just by that default, 3% saline gets used outside and we use mannitol in the theatre. In the theatre, we have mannitol 20%. And in terms of mils per kg, it is a really weird number. It's like 1.25 to 2.5 mils per kg. Honestly, for my own practice, I just remember it as 1 to 2 mils per kg and then take it from there.
So it's interesting hearing those differences because certainly when I was in Australia, mannitol was our primary agent, and then coming across to the UK, where I've worked, it is 3% hypertonic saline. So a real difference of practice. And again, I think an ongoing area which will be defined across time.
Mm.
So in this case, it was quite a prolonged case. It was around 4 to 5 hours in theatre, performing a decompressive craniectomy, taking up the fragments of bone and placing an intracranial pressure monitor in the form of an external ventricular drain. For a prolonged case like this and a trauma case, I'm interested to hear what the panel thinks about the decision to wake this patient up immediately versus to leave them intubated and have a period of neuroprotection in ICU, and about what factors go into your decision to make that. I might start with you, Dr. Geraldine.
It all depends on how the patient is, and also what was found intraoperatively. Of course, I have to have this discussion with this neurosurgeon in terms of if he was able to address the problem, and well, referring to possible bleeding or any other site of injury that should have been resolved with the surgery. But it all depends on the situation, really.
So it's a multifactorial assessment is what I'm gathering from you, about whether you think the problem has been addressed and what the future planning for this patient is in terms of scans and further intervention. Would that be a good summary?
Yes, exactly.
So,
we need to be coordinated with everybody who will be taking care of this patient.
Okay. And staying with that, can I ask, if you were to leave this patient intubated, what would your plan be in terms of keeping them asleep for the ICU?
Okay, first of all, we need to decide whether, check on the respiration of the patient. If there is some degree of dysynchrony, then we might have to start muscle relaxant infusion. But of course, before we do that, a first choice would be starting the patient on dexmedetomidine infusion. And then thereafter, we would choose propofol, just low dose for 24 hours if we really have to. And the next would be fentanyl infusion.
Okay. Dr. Charis, I might ask you, in Singapore, if you were presented with similar situations, any additional factors you would take into account with regards to the choice to stay asleep or to wake the patient? And how would you keep this patient asleep for the ICU?
Right. So we don't have an MRI or CT scan within the OT complex itself. And so the standard practice actually is to send the patient back to ICU and then scan the first thing tomorrow morning. So in most cases, the patient is going to return to ICU, intubated and sedated for the night. In my practice, if this patient comes to me to theatre first, I would then start the patient on a Presidex infusion and then continue this on in ICU. Mostly because in the morning when they want to wake the patient up, I don't want to be wondering if it is a long-acting agent that I've used versus there's something wrong with the brain if the patient takes hours to wake up after turning off sedation. But it is the ICU's practice to run a morphine and midazolam sort of infusion. So if they do come to us after a period of stabilization in ICU, that's what is used. And to avoid polypharmacy, I do carry that on.
Okay. And Dr. Payne, can I ask what your approach to this patient would be?
So for the plan of sedation in ICU, usually at the end of surgery, I will have a chat with the surgeon whether they feel that the brain is edematous or bulging during the surgery, or is there any ongoing bleeding, and whether they are going to put an ICP monitoring. So if there's a concern of raised ICP and they're going to put an ICP monitoring, either intraventricular or extraventricular ICP. So it's based on the if the ICP is raised, definitely need to be paralyzed. And the first choice of sedation in our ICU will be midazolam and morphine infusion. So if the brain is lax and the bleeding stops at the end of surgery, and they wish the patient to be extubated the next day, the next choice will be propofol and fentanyl. In our institution, dexmedetomidine is preserved for patient that is very agitated despite on midazolam and morphine infusion.
So it sounds like there's a general consensus that there's a multitude of factors that you're taking into account in terms of what the future trajectory of this patient is, but trying to choose agents that enables ICU to wake the patient rapidly if possible once that full assessment and initial treatment has been done. And certainly, I think in these very severe cases, there's some argument that can be had for a period of neuroprotection in the ICU, which I think all of you are advocating as part of your management. Well, I think that brings us to the end of the initial panel discussion. So what we might do is open up questions to the rest of the conference and go from there. Thank you.
Thank you.
Thank you.
Thank you.
Well, hello again to everyone, and we have some questions from the audience. I may just go straight into that if that's okay. So I think, Dr. Jose, I think the first question is to you, which is what would your hemoglobin target be for traumatic brain injury in a child?
Okay, thank you, Dr. Lanyon, for the question. So basically, we have to first identify the patient's state in terms of GCS score, whether he or she is of conscious or in a wake state or in a poor grade state, so that we can actually address whether this patient can actually tolerate um, um, blood transfusion and finding out what our hemoglobin trigger is. So, of course, there are a lot of reasons why we're trying to give blood, which is to provide adequate cerebral oxygenation. But then again, we have to also look into the other conditions that may actually affect cerebral oxygenation and perfusion. So to answer your question, usually we target around hemoglobin of 9 or 10. But for younger babies at that, as early as possible, we do transfuse blood in the beginning of surgery so that we have an allowance just in case suddenly the patient bleeds. We do have room to catch up. But for those who are 8-year-olds and older, then therefore we can actually have the blood available in the room, so we will be ready to give it once it's needed.
So it sounds like you're talking about what we alluded to during our discussion and trying to stay ahead of the curve so that you're not suddenly faced with quite severe hypovolemia if there's a sudden bleed from the surgical side. And then making sure in those older patients that blood is immediately available, not resting in the blood bank at the time. The next question we have is what is the youngest age you would use a cuff tube in? I might go to you, Charis, but we'll go around the group with this one.
Sure. I typically use microcuff tubes. I would avoid using them in neonates because I find by the time we reach about a 3.5, a good size tube that is seated nicely will produce a good seal, doesn't cause an issue with leaks during ventilation. But for older children, I do use microcuff tubes. I think Dr. Manikandan is not on the on this panel, but he did give some of his input to it, that he found that some of his children, if they were ventilated prone with the use of the microcuff tube, developed post-operative stridor. And I think this is the importance of checking the calf pressure, and also making sure that the tube is secure in place. And then when handing over to ICU, to remind them to check the calf pressure regularly.
I might ask you, Dr. Geraldine, Dr. Yi Yun, what's your practice with regards to cuff tubes in terms of age?
Almost the same as Dr. Koo. Depends on how bad is because if a case with polytrauma come with a lung injury, so very obvious they might have lung contusion, and during the intraoperative, the intrathoracic pressure ventilator setting may be very high. So, and they definitely need to be ventilated in ICU. So even though 5 kilos, I may need to use a cuff tube. Usually my cutoff point is 5 kilos. I have very bad experience in using cuff tube in neonates and smaller babies. Quite often, 2-hour surgery, post-op, after extubation, they will have post-extubation stridor and need to be given dexamethasone and adrenaline pen.
And Dr. Geraldine?
Yes, as much as possible, I normally do not use cuff tubes for neonates. The smallest tube that I usually use would be a 4.5 that is cuffed, because I worry about stridor, post-op stridor, especially on extubation, given the anatomical structure of the airway, of the trachea of the pediatric patient. So yes, that's how I normally decide on whether to use a cuff or uncuffed tube.
So yeah, our experience in the UK would be very much similar to what Dr. Charis said. And we use micro cuff tubes. We're lucky to have them available, and we would use them down to a 3 kilo child. Below that, you're looking at a 2.5 cuffed tube, and that's a very small tube, which is very prone to blockage. So that's not something I use regularly. The next question I have is, which value of sodium would you stop giving 3% saline at? And that's directed to Dr. Peng.
All right, that's a very interesting question. Firstly, we need to know what's the indication of giving the hypertonic saline. I only give when there's obvious features of intracranial pressure or the brain is bulging up. Probably I will start giving when the brain is more lax. And if you will want to give the hypertonic saline, definitely we want to take the baseline gases and look at the sodium level. You have to be careful. If the baseline sodium level show hyponatremia, you don't want to correct it too fast, and that will cause pontine deamylosis. So if the sodium level is normal, 135 at baseline, probably I would aim more than 140, and max in children, my level will be 150 for children. So how about the others? What's your thoughts?
Dr. Geraldine, I might ask you first.
Yes, we normally maintain at a slightly hypernatremic stage around 150 to 155. So that is our aim when we use hypertonic saline. And of course, this has to be monitored constantly, periodically at that, just to be safe.
And Dr. Charis?
I must say that I don't have experience of using 3% saline in pediatrics. But as my registrar used to tell me when I was working in the adult ICU, he said, well, are you going to decide to give mannitol or normal saline? Number one, you look at what the last person used. So the last person used normal saline, then you look, or the last person used 3% saline, then you say, okay, and then you look at the sodium. If the sodium is less than 155, you give normal saline, or 3% saline again. And if the person last gave mannitol, and you look at the osmolality, and the osmolality is now high, then you use the 3% saline. So essentially copy what the last person did unless they're over the target. That's survival tactics of night ICU.
I think that's very sensible in terms of an approach to it all. I think that has pretty much brought us to the end of our time for questions. So I would wrap it up there, and I'll hand back to you, Dr. Charis, if you wanted to close.
Yeah, sure. So, well, thank you all for joining us today, and thank you to every one of you from the panel for providing your input as to what you do in the conduct of neuroanesthesia around the world. I guess we have achieved our aim. We have many kids with similar presentations, but we have all different equipments and different environments to work with. And I think very often people tend to get fixated on what's right and what's wrong. I hope that all our differences here will be able to give people a little bit more answers or resolve dilemmas, hopefully also provide some assurance that many times, even with a little bit of variation from what you think maybe was suitable, would still result in an okay patient outcome. So yes, thank you all for joining us here today, and thank you all for being such great panelists.
Thank you.
Thank you.
Thank you.
Have a nice weekend
Yes, have a nice weekend, everyone.
and enjoy
And to
the.
our participants too. We shall all go and take a break now. Drink.
Bye.
Bye.